And hence there's a fluid sign seen on an MRI, which will not be seen on an X-ray. On an X-ray, you'll see a black hole, and on the CT, because the CT is done immediately, unlike an MRI scan, the CT, you go in and do it, you'll see actually a vacuum sign, because also CT does not pick up fluid. So these are characteristics that a CT will give a surgeon compared to what an MRI will give. The others, of course, again, this is a case from a book that I picked up. It's not my case, but these are classic, end plate disc erosions. It's intraosseous disc herniation that happens in osteoporotic degenerative conditions. But because there's a halo around the disc that's gone into the end plate, it gets considered as infection, and in our country as tuberculosis. And these guys are on an anti-TB treatment for years on end. But a CT will show you that there's a hole in that bone, as you can see in the bottom left image. You'll see massive osteophytosis, and you will see sclerosis. These are giveaway of infection. And if you see this of degeneration, not infection. So if you see this, just move on and stop worrying, and you'll be fine. Now here's another question, which is a curious question. Again, many of you all may challenge me on this, but I've had more than half a dozen cases so far, which have been post-operative discitis without infection. So I'm going to put my theory across here. This is an anecdotal theory, but you have to believe me that these 6 or 7 cases I have treated as post-op discitis with 0 antibiotics, and one of them has actually gone back to marathon running. So the theory here will be answered in question number 7. The question number 7 I wanted to address was, can discitis be prevented intraoperatively? And it is important for us to know that the disc is an avascular item in the body. The disc is not exposed to the body's immune system. And hence, if we go in and start curating out end plates during our discectomy, in trying to do a thorough discectomy or maybe a T-lift or a P-lift procedure, the parts of the disc particles can actually invade into the bone. The bone is immunogenic, and the immune system in the bone marrow will recognize this disc as a foreign particle. There will be an immune reaction which will cause succeeding lysis of the end plates and the bone, which will eventually settle down, sometimes with steroids, but not with antibiotics. So here is a case in point, which a T-lift was done with an aggressive end plate curettage. And I'm sure all of you all have had this in your practice. If you've done so many T-lifts, the cage just starts haloing around and the cage starts looking loose. And you normally just hold your horses because there's no other signs of infection. There's just local signs of pain and tenderness. So you don't give antibiotics because there's no soft tissue. So you stand back yourself, and we give bone strengthening medicines. If these are elderly patients, then we give teriparatide also. We give steroids sometimes, but no antibiotics, and they turn around, and this eventually settles in. Here's a question of biopsy, and I'm happy to take questions on this because this has not been spoken of and published, but this is this we see happening often. What about biopsy? So I would insist on a biopsy in all cases. I practice in the tertiary care center, which is slightly filled with hyper or over-educated patients. So you want to have a record, go on record saying that a biopsy was done. However, very, very often biopsy, because in post-op patients, antibiotics have already been given, biopsy turns out negative. So the big question here is, what do you do if your culture is negative? And the system that has to be followed is call up your microbiologist, ask for which organism is happening in your hospital. Ideally, call your ID specialist. Remember, ID specialists are over-aggressive. When you call them, they're going to say, take out all your implants first. So you tell them, I'm not taking off implants because that's going to destabilize the spine. You please advise me on the antibiotics. And invariably, you give 3 weeks of intravenous antibiotics, which are broad spectrum, and 3 weeks of oral antibiotics. Don't miss looking for upper respiratory tract and concomitant urinary tract infection, because that may lead you to the bug. So don't miss doing a urinary evaluation specifically, and you might find E. coli, just give the patient E. coli medication. Now, a controversy I'm going to rake up here, which is again very specific to our region, is anti-tuberculosis treatment. And my boss, Dr. Bhojraj, who is a very, very famous and very experienced surgeon, invariably gives rifampicin INH in all his discitis patients who have no culture positive, where the culture is negative. So his belief is that, so I'll tell you the theory behind this, that is again unproven, but I have used it when I'm at the end of the line. When nothing is working, I use anti-TB treatment. There are 2 theories. One theory why AKT works in discitis is that it's a broad spectrum antibiotic and it's not so commonly used, so it has to work. That's one theory, which is a common sense theory. The less common sense theory is that most of us who are in the subcontinent, the endemic zone for tuberculosis, are latent carriers of TB. And in any area in the body of immune compromise, like a post-op area, the latent bug comes and starts settling in, and hence there's a possibility that the bug there is, a tuberculosis bug, and hence this tends to work. If you have to go by what Dr. Bhojraj says, all his patients do well with this. Personally, I use this only in an SOS situation. I will not be in a position to recommend this to you, but certainly I'll be in a position to recommend avascular aseptic discitis to you. As far as, of course, Dr. Atik, who's very, very experienced in tuberculosis, is going to address this, but I had to make a mention of our very hard work paper. The protocol for medication in tuberculosis is now well established. We've done a prospective randomized controlled blinded trial of 50 patients in each arm, and we found that you don't need to give more than 6 to 12 months max of AKT. And of course, there's a protocol for MDR-TB, which we will not cover. Question number 10 is, do all your patients of discitis need surgery? And certainly not. Again, all of you who come from conservative surgical backgrounds will have had experiences of patients doing very well. As you can see, this is our patient, post-operative discitis after a laminectomy discectomy, but eventually so much bone erosion, a few months in bed, but eventually fully healed and fused. So you give the patient a choice. I can do a quick fix, or I can wait on this, and this will eventually heal with antibiotics. In tuberculosis discitis, once again, I'm sorry, I'm stepping on Dr. Atik's lecture, but I must show you some of our publications and some of our cases. The results of non-surgical treatment in tuberculosis discitis are extremely robust, and all the cases you see pre-treatment, post-treatment, they are jaw-dropping. If you see the amount of destruction that has been taken care of merely by medication, see the picture on the left and the picture on the right and the publication, they are jaw-dropping. So just don't worry. In Hindi, we say "darna mana hai," means you're not allowed to get scared if you see bad-looking TB MRI scan, because they will all respond to medications. And here's another case, and they actually get bony fusion, unlike the pyogenics, where sometimes you're worried about bony fusion. So the indication in my book for surgery in TB discitis would be, of course, worsening neurology or cauda equina, which is not that uncommon, I must say. Associated sepsis. If the patient has sepsis, you want to attack the source. Of course, if there's a lot of bone loss and especially late instability, I'll show you a few cases. And of course, the relative indication is the patient asking for a quick fix. So if the patient says, I don't want to lie around in bed, I don't want you to be taking pot shots at me, you don't have a culture that's positive, you please go in and take care. The results of surgery are dramatic, because their pain just disappears and they spring out of bed. So there is a role for surgery. Now, Manabu Ito was one of the first ones to describe this, but now it's become commonplace that we normally only fall back on fusion surgery. So if I have a discitis, I offer fusion surgery or nothing else. But now there's a lot of literature on endoscopic debridement, which is done potentially under local anesthesia. And the results from the authors, and you can definitely trust Manabu Ito, but there are many other authors, out of Korea, out of China, a lot of studies from China, which say that just endoscopic debridement can also take care of the symptoms. Personally, I have no experience with this. I do not offer this surgery, but I had to put this down here as the option available. For me, the approach is, this is the algorithm for surgery. So what is going to be my surgical approach? The decompression is always anterior, because the compression is always anterior to the thecal sac. The stabilization is always posterior, because the bones are best preserved behind. You're not going to get a good hold if you start putting screws in the cancellous inflamed bone in the front. The reconstruction again has to be anterior, because there's nothing to reconstruct behind. However, the approach is always posterior. To address question number 13 and 14, implants are permitted. It is now well proven, and interbody cages are also permitted. But as we discussed in the previous few slides, that if the defect is very large and the end plate is not too good, you may want to worry about this cage, and you may want to flip the patient and do a formal anterior harms kind of a cage, lest you have a problem. So we typically nowadays, even for larger cavities, put in bone chips and do what is called a chip lift, and we publish that also, where we pack in bone graft, stabilize the screws, and because there's inflammation and infection, this bone graft tends to heal very soon, much before the implants give way. So even in a big cavity, you can get a very, very good healing, as you can see in this case. The approach, of course, is all posterior. So you got to decompress anterior to the thecal sac, reconstruct anterior to the thecal sac, but your approach is all posterior. And typically you can get around it, doing your most favorite steps of T-lift surgery, as I've shown in these few sample videos. If you do a lot of lumbar T-lifts, you can start doing the same procedure for thoracolumbar and thoracic spinal regions, where you take away the facet on the side, as the top video shows you, and then you can create a good recipient area by scraping away bone. And just remember that when you scrape away bone, don't get overzealous, because everything like an ice cream will come out in your hands. You just take out as much as you need to create a nice slot to put in your cage. Otherwise, you'll end up having a big, large cavity. And this is an X-ray of anterior reconstruction done from the back. There was another one, bad discitis, and treated with all posterior surgery. So if you get smarter at doing T-lifts, it's not so difficult. In the thoracic spine, you can even cut a root. In the lumbar spine, you put the cage through, loop it between the two roots, and then compress, slightly undersizing the cage. But it gets easier and easier as time goes. Of course, if there is kyphosis, you want to do some kind of an osteotomy, which is again in an active infection, very, very easy to do, because there's not much hard tissue there. So you just go around, do a double T lift, so to say, take away tissue and close it down, and then you close the gap. You don't have to fill the gap up again. And finally, tips and traps and tricks. So I'm at the fag end of my lecture, but this is the most exciting part, trust me. Remember that the nerves are sticky. There's inflamed soft tissue. Do not remove too much bone. Dura is likely to tear because the dura is stuck. And if you tear the dura, woe be die, because the infection is likely to invade the CNS, and then you're in deep, deep trouble. I've had a death in my practice of a post-operative meningitis because of an infective, surgery for infective discitis. Now, what I'm showing you in red is what's going to lead to the conclusion of my talk, which is deficiency of the anterior longitudinal ligament, which is rife in chronic infection. This case happened in our unit 3 days ago. I think today is Friday. This happened on Tuesday. I was not the lead surgeon. My associate was the lead surgeon. You can see it's a chronic discitis, which because of instability was operated. And a simple bone grafting was done. While doing the grafting, the surgeon kept saying that Dr. Nene has had a very bad experience with this, so you must be careful. And he kept packing the bone in and see where the bone lands up. And if you can see here, the bone is well traversed anteriorly, and it hit a vessel, and there was pooling of blood. And luckily, just by packing away, we got away, and there was no major problem. But the ALL and the annulus is going to be deficient. The blood vessels are not pliable in the front, so they'll just rip through. And here is the case that I've been kind of building up towards my worst case, which was a discitis. So this lady had chronic back pain, and as is the style, was given an epidural catheter for her pain. That's it. It's quite illogical, but that's what was done, and that led to a discitis. So she was a de novo discitis of types, non-operated de novo discitis, who we treated with antibiotics for a long time, but eventually came with this chronic instability. And looking at the X-ray preoperatively, as you can see, we had planned an in situ fixation. However, the minute you put her prone, a large defect opened up. And all these are lessons learned. So I'm taking this stepwise. The minute you find that there's such a big alligator jaw opening up, you got to be aware that the tissues are going to be extremely loose over there. There's nothing holding it down. And we went in and did a 13 T-lift cage reconstruction. And once again, overconfident, super fast surgeon, that is who I am. I just put the cage. I said, let's start closing. Okay, quickly get an X-ray. And the X-ray showed that the cage was several millimeters ahead of the safe zone. And I said, this is not happening. So what would I do? I'm again taking you through the steps of what I did. I went back in. I just distracted the screws. I took the rod. I kept the rod in place. I distracted the screws, took a caulkers and tried to grab at the screw and grab at the cage to pull it back. Now, you've all had experiences of reaching out to soap when you're having a shower, and you catch the soap and the soap slips off. And that's exactly what happened here. The cage just slipped off from the caulker. It disappeared, and it got replaced by liters of venous blood. And this was extremely unnerving. Everyone was trembling. We were going to lose the patient, but luckily, yes, we are almost finishing. So we packed, prayed. We could get the under control, and with the pack inside, we did a single layer closure, turned the patient around. And before, this is the X-ray we took while we turned the patient around. And because I was familiar only with the lateral, I was not familiar with the straight midline approach before the surgeon came. We took a left retroperitoneal approach because the cage did look like it was on the left. And we started digging around. We reached the space, we could take the pack off, and again, it started bleeding. Again, we packed. So over many, many times, we eventually could get out without leaving a pack inside by underrunning sutures, and the patient stabilized. Well, this is not the story. The story starts now. Of course, we felt the cage was lying retroperitoneally, so we chose not to look for it. And we just, and the bleeding stopped. She was transferred to the ICU. This is the X-ray on day 1 in the ICU. She was still intubated. We didn't want her to cough and open up the clots because we had not found the bleeder. You should take a close look at these X-rays because they tell you the story. And that's X-ray on day 2. Again, take a close look. because you will remember, the X-ray when we come back to what actually happened. The patient started walking around on day 3. I asked for an X-ray, and this is what the X-ray looked like. So surprise, surprise, there's no cage there. So where the hell is the cage? So I thought, okay, this cage is dropped into the pelvis. So I asked for a PBH X-ray, which didn't show anything. I asked for a CT scan, and the CT scan also didn't show any cage. And I remember this. I was talking to the radiologist from my house, and I said, look, buddy, you can't find this cage. It's a 13 titanium cage. If it's not in the abdominal cavity, I'm sorry, I'm going to ask you to do a chest CT scan. And his jaw dropped also. He said, why chest CT scan? Well, because the cage had gone up through the pulmonary, through the IVC, into the right heart, into the left heart, shot itself as an embolus into the pulmonary artery. And there it has stayed since 2008. It's 12 years, and the cage is still there. And if you now see these X-rays, you'll see the cage actually tracking up, which looks like an ECG lead. Is actually the cage tracking up on successive days till it reaches its destination. Fortunately for me, my wife is a chest physician, and she came in and gave me advice about what how you should take care of this, because there was very good perfusion, very good oxygenation distal to this pulmonary artery. We kept doing successive CT scans, and eventually we chose not to do an open heart aorta clamping surgery to remove this cage, and we left the cage back, and now it's 12 years and she's there. And I can tell you, this is the quickest acceptance of a spine article for me. It was accepted in like 4 days. So to end, these are the questions that we asked, and these are the answers. And sorry for overrunning time. Thank you so much for having me over, and I'm hoping to learn from your experiences also.
Thank you so much, Nini. Thank you. Fantastic talk. But every case of you need one lecture. Every case of you present case for every case we need a one lecture time. So let me shift to Luay. Luay, please, can you share your screen and share your case? I'm sure Nini you will face a lot of questions.
Yes, I'm back again.
Yes, please share your screen.
Yeah. Thank you for all of you. I'm Dr. Luay, a spine surgeon from Bakuba Teaching Hospital. I will show you a case of Spondylodiscitis. I managed it a few years ago. I have not disclosure regarding the history. This is a case of a 67 years old man, has a history of single level discectomy through a classical approach, hemilaminectomy did in somewhere since 18 months. He had the history of 1 week following the surgery, a growing low back pain with low-grade fever, and wound healing problems. At time of presentation, 18 months from the surgery, the patient cannot change his position in his bed, cannot sit, cannot move any more from the bed, and surprisingly have no radiculopathy and have normal sphincteric function. His past medical history is a diabetic, non-insulin dependent, and he's a very heavy smoker patient. The patient during last 18 months, he treated by his son. He's a surgeon, general surgeon, surprisingly by antibiotic and some analgesics. Regarding the examination, at time of presentation, the patient looks very, very ill. Really is in a status of septic shock. Is pale, severely malnourished, dehydrated, and have very bad bed sore from the long standing staying in his bed. Regarding the neurological examination, he has all things are normal power, normal sensation, and I can't do any stress test because of he cannot tolerate any movement. And this is the picture of his bed sore at the sacral region at time of presentation. The lab tests, all of them are show very bad result. The hemoglobin was 7.3, white BC, the severe leukocytosis to 23,000, and CRP elevated, the ESR 130, and the blood culture we did it twice for aerobic only, was negative. radiological examination, we starting with the plain X-ray, show the severe sign, very clear sign of long-standing discitis following the surgery, the erosion of the end plate of the L3-4 and 4-5, and severe collapse of the L4 vertebral body with loss of lordosis and sign of instability. The MRI shows, and here the L4-5 T2 image shows the signs of the ongoing or severe discitis, the hypointense in T2 and L4-5, and there is a big hypointense area in the lateral recess of L4-5. As unfortunately, you cannot do enhancement because of the bad renal function, and to differentiate whether it is fibrosis or disc fragment. L3-4 as well, there is sign of the same thing, and this is L2-3. So we progress for CT scan, as Nini said, to evaluate the bony destruction, the amount of bone destruction, because we feel that the patient is in severe instability, and we have to do that as a routine part of planning for surgery. Here, the CT scan at the time presentation, severe bone loss of L4, destruction of the end plates, instability, and there is some fusion between L5S1. Here, another look at the level of the L4. The patient do laminectomy at this area. And now, what to do? What the option for this patient? I don't know from the moderator, can I progress or somebody has to comment?
So can you give us some questions or like some options in your case?
Yeah.
Like, do you want to ask the yes for some questions? Yeah.
These the questions for this case. What are the priority in the management? This is my first question, because the patient in state of a septic shock is severely ill patient, and is there a place of conservative treatment or management? And if it is a surgical case, what is the main indication for surgery in such case? And what are the best plan for surgery? Yes.
Okay. So we will try to discuss these cases at the question and answers after we finish the other speakers talk. Okay. So I will return back to you, Luay. Thank you, Luay. Thank you so much.
Yes, thank you.
Yes.
Can you share your screen? Please go ahead with your TB spine.
Okay. So I am going to cover the tuberculosis of the spine, and I have only very few questions that the early diagnosis, how to do the early diagnosis, and what is the surgical management of the tuberculosis of the spine. We are very unfortunate that we are still receiving the patients like these, which are found in the Egyptian mummies with the tuberculosis, and we see a lot of complications of these tuberculosis patients. It is because we do not diagnose it in time. You can see this patient who is holding his head with his hand because he has a severe pain, and he is going to the different hospitals from the last 3 to 6 months and remained undiagnosed because there was not a good quality X-ray, and it was not picked up by the non-orthopedic surgeons, which shows that there is a destruction of the vertebral bodies from C6 to T1, and there is a increased soft tissue shadow in front of these vertebral bodies. So when we go for the MRI, you can see that there is a lot of pus which is lying in front of the vertebral bodies, and these shadows should be picked in the X-rays also. So when we go for the operation, we approached anteriorly, and you can see that there is a fountain of pus which is coming out from this neck, and this patient is suffering from how much pain because of the delay in the diagnosis. So we have done the anterior decompression and cage in this case, and this patient was neurologically intact, so he start walking immediately after the surgery. This is another case which shows that there is a D12L1 vertebral bodies and plates destruction, and actually this tuberculosis, it does not have a frank pus. It will appear as the caseous material like this. This is again an anterior approach, and if you found this caseous material, there is highly chances that it is a tuberculosis of the spine. Another case is which shows that there is a D10 and D11 destructions of the end plate vertebral body, and you can see that there was delay in diagnosis, and there's so much pus is lying that you can even see from the outside, but nobody bothered to see the patient from the back, and this patient is suffering from the pain from the last so many months. So the purpose of showing these cases is to emphasize on the early diagnosis of the tuberculosis, and we should not miss the diagnosis. We should properly examine the patient and do the investigation and then do the treatment. These are the post-operative x-rays of this case. Now, this is another case which shows that she is a 50-year-old female who has presented with the pain in the lower back. Although the thoracolumbar junction was not so much tender, she had a pain, radiating pain to the left lower limb, but she was neurologically intact. The x-rays shows that there is a D12L1 disc space, it is reduced, and on the MRI you can see that there is the involvement of the end plate, but the disc you can see there. This picture can mix with the pyogenic discitis. So we have done the CT guided biopsy, and it shows that it is a tuberculosis. So the question was that what we should do, what is the indication of surgery, because this patient was neurologically intact, and her MRI, it shows that there is not too much destructions of the vertebral bodies. Here I want to mention that for seeing the destruction of the vertebral body, do not rely on the MRI. Either the x-rays are a very good guide. So if you see on the x-rays that the vertebral bodies, the bones, they are visible, they are not so much destructed, then decide on it the stability, or use the CT scan, but we rarely use CT scan in our practice. So if we see the indications of surgery in the tuberculosis of the spine, the most important indication is the neurological deficit, if it is present, or to prevent the late onset paraplegia. If you think that the patient is so unstable spine that its kyphosis will increase, which will increase the stress on the spinal cord, you can go for the surgery. That is an indication of surgery. And other is the stability. If you, by all the principles, if it is an unstable spine and you think that the kyphosis will increase, that is an indication for surgery. And where there is an abscess, it should be drained. So if you see the abscesses, like I have shown you in the cases, if there is a paravertebral abscess, that is an indication for the surgery. And in case of resistant ATT, usually it is better to go for the debridement and remove the dead and the necrotic tissue. It will help in the early recovery of the patients. So these are the indication of surgery. In this patient, the female which I have shown you, it did not have a neurological deficit. It was not an unstable spine. It was not resistant to the tuberculosis. There was not too much paravertebral abscess. So we have treated it conservatively. The next question is, what should be the approach to the surgery if we have decided the surgery? So this is another case which shows the tuberculosis of the spine at D6 and D12. There's an end plate destruction, which is difficult to pick up on the x-rays because of the mid-thoracic region. So if you go for the MRI, you will see that there is the end plate destruction, although the part of the disc, it is lying there. This patient admitted in the hospital with the pain without neurological deficit, but within 15 days of the admission, he developed the neurological deficit with the paraparesis. So he was shifted to us, and we decided to go for the surgery because that is an indication of the surgery. So now when we decided for the surgery, we have these different options: either do the posterior decompression alone, posterior decompression and instrumentation, anterior decompression and cage, anterior decompression, cage and instrumentation, and posterolateral decompression, cage and instrumentation. So we decided for the anterior approach, and the anterior approach, it is usually called the Hong Kong procedure, in which we go anteriorly, usually retroperitoneal, do the radical debridement, do the decompression, and it will also help in the correction of the deformity. If we use some instrumentation, it is called the modified Hong Kong procedure. We usually do the thoracotomy, so we remove the part of the rib and we use it for the bone graft. The bone graft can be used like this. You can break it into 3 pieces, put the screws in it, put that graft into there, and then do the instrumentation. We are nowadays using the hard titanium cages. These are the hard titanium cages, and these are hollow from the inside. We put the morselized bone graft, that is, if we are using the thoracic spine, the thoracic rib, and we put that cage. We put that cage in anteriorly. This is the lower end and this is the upper end at the anterior 2/3 of the vertebral bodies. And usually this bone, it consolidate and it unites at the proximal and the distal of the bone and plates if it has been pressured properly. So this is that case in which we have done the anterior decompression and cage. He's a driver and he's nowadays working. His paraplegia, it gets improved after the surgery within 2 months. In tuberculosis of the spine, the paraplegia is very responsive. Even if the patient is paraplegic or paraplegic from last 6 months or 1 year, it responds to the surgery. The other approach is the posterior approach. Right? It is in the posterior approach, one thing is the laminectomy. But remember that the laminectomy can convert the Pott's disease to a Pott's paraplegia, because the anterior part of the spine is already involved. And if you destroy the posterior segments and the posterior parts of the spine, it will basically minus one segment of the spine, and that can causes the deformity and then the paraplegia. This is a case example in which there was a paravertebral abscess and the destruction of the T5, T6 vertebral bodies, and somebody has done the posterior decompression. And due to that posterior decompression, the whole segment, there is absence of the whole segment, and this will lead to the increase in the deformity, and the patient presented to us with a paraplegia. So we have done the anterior debridement, put the cage in it and put the plate over that because it was an unstable spine. The posterior segments or also laminectomy has been done. So this is the cage. We placed it, put the plate on it. This is simple DCP plate. You can use the transpedicular screws also for doing this fixation. And the patient's neurology, it has been improved within 3 months. But the posterior approach is indicated if the tuberculosis is only posterior, like in this case. All the pathology is posterior. So you can go posteriorly and can do the posterior decompression. Or if there is a rigid deformity and you want to correct it by doing the vertebral column resection, the posterior approach is indicated. Then you can have a combined anterior and the posterior approach in which you go anteriorly and do the anterior decompression in cage, and then turn around the patient and go posteriorly and do the transpedicular screw fixation, and that is called the Calafong procedure. Then we have a posterolateral approach. In the posterolateral approach, usually from D2 to D5 is the area where it is difficult to go from the anterior approach. So we go from the by doing the costotransvestectomy, and this is also basically we are going anteriorly, but we are taking a little bit off center approach and remove the bone and then reach anteriorly. And if we remove part of the ribs, then it is the modified costotransvestectomy. Then this is the posterolateral approach. The posterolateral approach is like you do in the TLIF. You go from the posterior, you get the transforaminal approach, or you do the PLIF, and you put the cage anteriorly and put the transpedicular screw fixation. This is basically you want to work anteriorly, but you make the window from the posterior just because you are familiar with the posterior approach, and you also want to do the 360-degree fixation. This is an article which compared the anterior versus posterior approach, and it says that it has the same clinical outcome in terms of the correction of the angle, loss of correction, fusion rate of the grafting bone, and complications after the surgery. And therefore, we prefer the anterior pathology must be approached anteriorly. So at our center, we prefer to go anteriorly in the tuberculosis of the spine because you can deal with the abscess, necrotic bone, decompression, and you can get the tissue for the histopathology very well from the anterior approach. You can also deal with kyphosis from the anterior approach and can causes the fusion of the pathological area in a better way if you have everything in front of you. And you can do the anterior instrumentation as I have shown you in my presentation. And by the rules of biomechanics also, the spine is like a crane, and this is the spine. And if it is destructed here and you will destruct the things posteriorly, then everything will collapse because we know that the all cylinder, if you remove this posterior segment, the everything will collapse. So there will be a death of a column. So we know that the all cylinder long column collapse when structurally weakened in the middle. So what we do is that everything posterior is normal, right? Nothing has happened posteriorly in the tuberculosis of the spine. So you just go anterior and distract anteriorly the vertebral bodies, but there is a lot of forces anteriorly. Therefore, you have to put something hard here that keeps these bones separate from each other, and it will fuse with time. And you can achieve your goals very well from anteriorly by doing the decompression and removal of the dead and the necrotic bone. And if you remove the column of the bone, then basically what you are doing is that you are doing the shortening. And if that shortening can causes the kinking of the spinal cord, which will compromise the vascularity of the spinal cord and can causes the damage to the spinal cord. We have done almost more than 1,000 cases at Gurki Trust Teaching Hospital under the supervision of the Professor Amir Aziz. He is nowadays the AO Spine elected chairperson. And we have applied these hard titanium cages with the bone graft from the anterior approach almost at each and every level of the spine. And I will show you the cases. So we have done almost 1,415 cases. This is just a surgical audit. We are in the process of trying to publish it somewhere. And we have found that it has the very good functional outcome. And almost 90% of the patients, it works well. And the kyphotic angle improvement, it is in the 80% of the cases, it is more than 10 degree, and in 16% of the cases, there is kyphotic angle correction. This is after 3 years of the follow-up at least. And basically the neurological improvement can occur even without surgery, but if you have done the proper decompression even posteriorly, it can causes the neurological improvement. We have published our cervical spine anterior standalone titanium cage without anterior plating, and in that paper we have proved that there is no added fixation is required for supporting cages in the caries spine, even in the cervical spine. So I want to show you the few cases at each level with the follow-up.
Atik, can you just become a little bit fast and select one case, yes, please, and then because of for the sake of time. Thank you, brother.
Only 5 minutes.
Okay.
There is C2, C3 tuberculosis of the spine. The anterior decompression in the cage has been done, and you can see this is the 11 years follow-up, and the patient is okay. And see which area it is. It is around C3 and C4. Similarly, this is the mid-thoracic region. Anterior decompression and cage has been done, and this is the 11 years follow-up. No kyphotic angle increase, and the patient is doing all his activity. This is also the mid-thoracic region. I just bypass it. This is also mid-thoracic region. This is 10 years follow-up, and nothing happened to this spine. This is the thoracolumbar junction, D12L1, which is the most unstable area, and the excessive movements at this area. The anterior decompression standalone cage, and you can see there is a 7-year follow-up, and there is no increase in the kyphotic deformity. This is L3, L4, the lumbar spine, and the anterior decompression and cage has been done, and this is the 7 years follow-up, and the patient is doing all movements of the spine, and there is no increase in the kyphotic angle, and there is no loss of lordosis. This is a separate topic, the pediatric spine, and even in the pediatric patients, we are doing the anterior decompression and cage. In this patient, there's a lot of pus. We have done anterior decompression and cage, and this is the 3 years follow-up, and the cage is at its place, and it does not cause any problem. The 7 years follow-up, the 8 years follow-up, this is the cage, and no, this is the lower cervical spine, the most mobile segment of the cervical spine, and see the length of the cage, almost 3 vertebral bodies they are involved, and they have been removed, and there is only standalone cage, no instrumentation, and this is the almost the 8 years follow-up, and it is okay. See the length of the cage here, almost 4 vertebral bodies has been removed. This has been done because of the redo cage, and the patient is fine. So the take-home message is that early diagnosis and treatment can result in complete resolution. Advanced destruction of the vertebra results in permanent disability, which requires complicated surgery for correction. If paraplegia develops, 80 to 95% can still recover with adequate treatment. Anterior decompression and standalone titanium hard cage with bone graft is a valid method for the tuberculosis of the anterior spine. Thank you very much.
Thank you so much, Atik. This is an excellent work. I have heard and saw your cases many times in the congresses. I congratulated you in Pakistan and your colleagues for this nice work, but you raise a lot of debates about the biomechanical stability of putting multi-level anterior cages in cases at cervicothoracic junction and thoracolumbar junction. We can debate for the whole day for this, but I congratulate you for the result. My message here from these 2 talks that we have to clearly define and identify whether this is a case of TB, spondylodiscitis, or it is pyogenic spondylodiscitis, because it's not only about the conservative management, it's also about the method of treatment, the approach, whether to go from posterior, from anterior. It's different, because with the TB spine, anterior reconstruction is something very important, because we have a lot of, or there's a lot of papers published about the late sequelae of kyphosis, while for the pyogenic discitis, rarely we need to do anterior reconstruction. In most cases, things can be solved from posterior, unless we are dealing with the cervical spine. So let us continue with Ghazwan. Ghazwan, please, can you share your screen? Ghazwan will speak about spondylodiscitis in non-spine surgery.
Hello there. Are you hearing me?
Yes, yes, Ghazwan.
Yeah. You know, I'm just imagine myself, untrained goalkeeper, stand in his goal in front of Messi and Ronaldo. So, what else should I present or continue? So sorry for putting me in such situation.
You have to define who is Messi and who is Ronaldo.
Both of them the star. The problem with me rather than with them. So this is my face now. Actually, nothing to be disclosed. Learning objective, I will define spondylodiscitis, highlight the early diagnosis, plan for treatment, case presentation, and take-home message. So the job that we did with my mentor, Dr. Haidar Qatran, I don't think that he's available now. With the project I will tell you later. By definition, it's infection of intervertebral disc. It could be a wide range of disease, ranging between discitis, spondylodiscitis, epidural abscess. We saw many cases from Ninia and Atiq. And also in the last year, it's become not uncommon disease because of comorbidities, diabetes, and immune insufficiency. And it could be happen spontaneously. There are many papers published about spontaneous spondylodiscitis, or it could be after spine surgery. And Leoneg, who first described the pyogenic spine infection in 1879, followed by Koloshi, who published a first series of pyogenic spondylodiscitis. So, but our cases that I will present it, in which that spondylodiscitis that developed after spine surgery, in which the patient underwent surgery under general anesthesia elsewhere in the body and developed spondylodiscitis. So I just want to first to define my term, whether I call it spondylodiscitis, whether it is a spondylodiscitis after spine surgery, or whether any other let's say definition. I ask Ahmed just to send the poll to take the message from all the participants. We have many experts in the stadium now, so just help me to define the term. So if we continue with this topics, the annual incidence is about 2.4 per 100,000 of cases, and it is a bimodal distribution, below 10 and above 50. Male to female is about 2 to 1 to 1.5, which is more common in male. And the main problem in this pathology, it's the delayed diagnosis because of non-specific symptoms that appear in the initial symptoms. So most of the patients are treated elsewhere by non-specific treatment that make the patient presented in delay manner. So route of infection, it is either hematogenous, which is the most common mechanism of infection, or external, which is seen in spondylodiscitis, or from adjacent abdominal tissue like psoas, abscess, and other. Most common microorganism is Staph aureus, but we saw that in our data there is a significant number of cases with the gram-negative, especially the E. coli, as Nini said, and even we have anaerobic infection like Bacillularia infection and the other. The level involvement in most of the published paper, the number is fine. It's about 40 to 80 in various papers. Second, it's the dorsal, and the third is the cervical spine. So as I mentioned, the non-specific symptom of the disease, and in our series, what we saw, that's when the patient underwent surgery like the gynecological, obstetric, or any else surgery, and developed back pain, which was neglected, but from our experience, this is last let's say 3 years, we start to define, and we start with the complete workup with the cases. So some cases attend us we can diagnose them directly or easily or early, rather than the case that's referred from the other doctor or other centers. But surprisingly, that serious symptom could be happen, even multi-organ failure and death rate, which is up to 17%. This is our series. We collect about 40 cases of patients in which they underwent surgery elsewhere in the body, and the ratio of male to female ratio is more common in the female. I will figure out why, because the surgery that they underwent is mainly gynecological, obstetric, or plastic surgery. The presenting symptom backache is the most common in about 28%, 28 patients, while the level involvement is more common in the lumbar spine, and it's more common single level. We have 2 or 3 level also. Blood culture is positive only in 17 cases, while the comorbidities is less, as seen in this series. These are the previous surgery that the patient underwent, which is more common. The cesarean section is about 30% of cases. Other cases summarized between rhinoplasty, laparoscopic cholecystectomy, even ACL reconstruction, sleeve surgery, diagnostic curettage, and the others. A blood culture, these are the result of blood culture, and these are the result of biopsy, which is positive only in about 70 to 75%. We follow the guidelines of the treatment as published in Doret et al. In 2013. That if we have any patient that's suspected with new onset of back pain and history of surgery as well, we will start with the plain X-ray, MRI, and CT scan is only indicated in some cases. That's when advanced disease and we are planning for surgery, and also we send for a blood test. And if the MRI is positive, that's confirmed the infection with the blood test. And if it is negative, so we didn't send any case actually for radioactive scanning because we don't have, and also we confirm the infection after that by taking the biopsy. These are the results of the mean results of our cases. 45% that elevated the blood cell count. ESR is positive in more than 85%, and 95% CRP is positive. Radiology, the MRI is the most sensitive in our study, and the CT scan we did only in advanced cases. That's when we are planning to do the surgery, as I will mention later on. A blood culture, as I mentioned, about 40% positive, while the disc specimen culture we did fluoroscope guided and the CT guided. Just we kept it for cervical cases, about 3-4 cases, because we don't have the facility to do CT guided, so we send the patient to the other city rather than Baghdad. These are the management. So after confirmed the diagnosis by CT guided, and if the patient doesn't have any symptoms of instability, chronicity, failure of conservative treatment, and confirm the pathology, we will go for conservative treatment by 6-week antibiotic actually, and another 6 weeks by oral. As Dr. Nini said, there are no guidelines about the duration of antibiotic. We check it in the literature, but the most important and factor that we determine and depend, and also it's mentioned in previous papers about the clinical improvements, and the C-reactive protein titer start to decrease. And if we didn't get any blood culture, whether from a blood, any positive culture, whether from a blood or specimen, we start with empirical antibiotic. And also, are you hearing me?
Yes, Ghazan, go ahead.
Yeah, we will continue with the empirical antibiotic that's cover gram-positive and gram-negative, and in some cases even we add the anaerobic, and we keep the surgery for cases that not respond to treatment, and also in some other cases that present initially with advanced descriptive disease stages. These are the result of our treatment. About 70% treated conservatively, while the other we choose the posterior approach, and one cases we did 360 instrumentation, as we will discuss later, and for cervical we did ACDF and or ACF one case. Case 25 with history of dilatation and curettage 8 weeks ago, presented with 4 weeks neck pain, and they started last 3 days with weakness, with even the are the and that show that spondylodiscitis with pus extended to the canal and causing her symptoms. This is the CT scan that show advanced instability, and this is a case of Dr. Haider that he did anterior cervical corpectomy and diffusion. And the second case, 28 years old, with history of rhinoplasty, and this is the site with no any features of instability or neurological deficit. We treated her conservatively according to the culture and the sensitivity. And the third case was, this is advanced, which is history of breast lump excision 3 months ago, presented with back pain that started 1 week after surgery, with multiple trial of conservative inconclusive treatment, and this her data, and we did posterior spine instrumentation with debridement, and treated her, followed by antibiotic, and she did well, and she's now in I think in month 10 or 11. So I think that the take-home message that spondylodiscitis after non-spine surgery is a real problem, and we face it not frequently, but we see it because our series is the biggest series it will be published soon. And the spondylodiscitis following non-spine surgery required high level of suspicion. So in order to confirm and the diagnosis and the start treatment, early diagnosis and prolonged treatment has higher successful rate, and surgery is deferred for advanced stages of disease and neurological deficits and failure of conservative treatment. Thank you.
Thank you so much, Ghazwan. Thank you. May I ask Luay, please, to present the solution of your case, because we run out of time. Luay, can you hear me? Yes, Luay? So while you are preparing your sharing your screen, Nini.
Yes, I think he has a problem with internet.
Yes, try to fix it from your side, Nini. There is a question
Okay.
for you. You speak a lot about the surgical management. What about the conservative treatment of these cases? I mean, we all know that there is certain indication for surgery. And what about the rigid bracing? Are you with the rigid bracing for cases with early spondylodiscitis, when there is no neurological deficit, no instability? And for how long you will keep the patient on rigid brace?
So I don't use braces at all in my practice, and I
Okay.
believe in the muscle spasm to work as the brace, and that limits their activity. So if a patient has a lot of pain, he's not able to get out of bed, I don't believe by giving him a brace, he will be able to get out of bed. So I'd rather that he's in bed and the muscles will decide. As far as conservative treatment is concerned, we discussed it in the chat that ideally you should have an organism. You do a biopsy. If it's negative, look for the organism in other potential sources in the body, including the urinary tract, the respiratory tract, some skin lesions. If you still don't find anything, discuss with your ID specialist and start a broad spectrum intravenous antibiotic covering MRSA along with a gram-negative spectrum for 3 weeks. Then send the patient home with oral antibiotics for 3 more weeks.
So your conservative is only antibiotic. You mean by conservative treatment is only antibiotic?
Yes, sir. No brace, no exercise.
But antibiotic is part of surgical management also. I mean, it included in both, in the conservative or surgical. What I mean that, do you have an option to put the patient on for bed rest or something like that? Because we all know that these are the segment which is potentially unstable. It's not unstable, because if it's unstable, you will go for surgery, but potentially unstable. And this movement will elaborate more pain for the patient. So no rule of brace, no rule of bed rest for you?
No, Buzheim, that's what I said, that I rely on the muscle spasm
Okay.
to take care of the bracing. And if the
But
muscle spasm is so much that despite that, he's unable to get up. So if a person has so much pain that he's not able to get up, I don't think by giving him a brace, I'm going to be able to make him get up. On the other hand, if he's able to get up without, with reasonable pain, I personally don't believe in braces, and I've been okay with that.
yes, Atiq, Atiq, question for you. It's the same question for you. Can you hear me, Atiq? Unmute
Yes,
yourself.
I can. Yes, I
Atiq.
can hear you.
We
I
have-
agree with the name that.
Yes, but what we have seen you put in only cage without fixation. So did you put your cases on brace?
Yes, I have answered in the chat box also that the difference between me and Abhinain is that he do not likes the brace, and we put the patients on the brace. So we put the patient on the brace for 6 weeks after the anterior decompression in the cage. But that is just because we are afraid that something doesn't happen with the spine. Why it is stable, this standalone cage, why it is stable? This is the question which has been asked. Remember that this cage is only effective in TB spine. Don't think that in the pyogenic spine or in the trauma, you will do the standalone cage and it will remain stable. There you have to decide what are the conditions. Why it is stable in TB spine? Because the anterior longitudinal ligament is either intact, or there is a fibrosis in front of the anterior longitudinal ligament that keeps the things stable. The posterior elements, they are normal. The ALL is intact or fibrosed, but it is present there. So everything is stable. You just have put the cage in between and the things, it becomes normal. So that's why even in the thoracolumbar junction and in the cervical spine, it does not displace anywhere. And when you put the instrument basically over this cage, like the plate, it will prevent the compression of the spine. And when it prevents the compression of the spine, it makes the cage more unstable, because when the spine it compress, it just hold it the cage within the spine. But if you put the proper length of the cage, everything will become like a normal spine, and there is no danger that this cage is going to be displaced. The only thing that people say is that it will increase the kyphosis. There is a collapse of the vertebral bodies if the bones, they are not strong. But 2-degree or 3-degree collapse, it doesn't matter for the patients.
Nini, nowadays there is a trend toward percutaneous fixation. Percutaneous fixation in cases of spondylodiscitis, bridging the infected part. What's your opinion?
So I think it's one of the few indications where a aggressive or a fully open surgeon like me would also consider doing percutaneous fixation, because all you need is stabilization and the antibiotics do the reconstruction. So the indication for surgery, if it's pain because of instability, a percute fixation, I think one of the rare indications in my practice. But you've hit the nail on the head, Muzahim.
Thank you. Okay, Lloyd, please, can you share your screen and go ahead with your case?
Yes, Muzahim. Sorry for the bad internet. Please accept my apology. Now we come to case solution, and I'll try to mention a few points about the indication of surgery in general in spondylodiscitis. First indication, of course, is the neurological deficits, sepsis, intraspinal empyema, the presence of ventral or paravertebral abscess of size more than 2.5 cm, failure of conservative treatment, and of course, spinal instability. What the aim of the spondylodiscitis treatment? We can configure this title in 3 steps or 3 parts: the elimination of the focus of the infection, the second, restoration of spinal functionality or stability, and finally, reduce pain. Regarding our case, which is I will try to memorize your the history for you, that the patient come in the septic shock with bed sore and severely ill. For the elimination of the focus infection, probably we would first thing come in our mind that the patient has deep-seated infection in his spine. I have a severely distracted disc and the body of the vertebrae. but I think the patient come after 18 months to the hospital seeking medical care. Is that the bed sore that bring him to the hospital because he now in sepsis because of the severe extensive cellulitis and fasciitis. So I think we have to. My thought for that is I have to start with this first because put the patient in severe distress and in severe serious situation. And the second thing is that to block the access for my next definitive surgery in his back. So I did a bed sore extensive debridement and primary closure. Antibiotic. Unfortunately, the bags or gem cannot be isolated with any mean because, as I said, he is a father of a general surgeon and he received a lot of things over 18 months at his home. And I plan for improvement of nutritional status, optimization of general condition, and especially the renal function. And the patient over 2 weeks of this medication and management, his general condition improved significantly, but still have severe or extreme difficulty to move in his bed and change his position to get to the toilet or to bedroom, from the bedroom. The second aim is the restoration of the spine functionality or stability. If we look to this lateral plane X-ray, and this is this CT axis, we can estimate that how much the spine is unstable. The segmental, the criteria for instability, I use the segmental kyphosis more than 15 degrees, vertebral body collapse more than 50%, and a translation more than 5 millimeters. All of them are clearly present. And now the question, how to approach this case? Is it anterior or posterior or combined? And I will put here, this is really, I think it is a matter of the disease, and it's a matter of the experience and individualized according to the case. Many literature shows that something is better than that. For example, this is say an ETL showed that the single anterior procedure result as a better outcome in aspect after 1 year in aspect of the level of function or ODI. Next to the minimal invasive transverticular stabilization combined vertebral debridement lead to faster recovery, and others shows that the single posterior procedure caused significant loss of sagittal balance post-operatively. Minimal invasive procedure such as retroperitoneal trans-psoas approach like XLIF permit removal of site of infection, good restoration of lumbar lordosis, and so on. And of course, the posterior approach including the TLIF application. This is my solution. I did for this case two-stage surgery separated by 7 days. I do a full corpectomy of the L5 through anterior retroperitoneal approach and partial corpectomy of the L3. I put expandable titanium cage and packed with the graft. Really, my indication was in this surgery not to deeply compress to the neural tissue, because as I mentioned that the patient have no neurological deficit and have complaining of no radicular pain. So my main indication was just to solve his problem of instability. I put expandable cage, not ordinary one. So in order I flip the patient in a prone position and did a posterior transpedicular fixation from L2 to iliac bone with posterior fusion 2. The antibiotic protocol I use levofloxacin, which is continue for 6 weeks, 2 weeks with an IV, and 4 weeks in orally. There is a lot of things about the antibiotic duration mentioned. One of the best paper from Bernard et al. Yes.
1 minute.
1 minute. Yeah, but because it is RCT for almost 350 patients, state that a 6 weeks course is not inferior to that of 12-week course treatment in the term of the after 1 year result. And the guidelines of the Infection Disease Society of America states the same thing. Regarding whether to use antibiotic IV or oral, the Infectious Disease Society of America guideline propose oral therapy in the case of a good oral bioavailability as possible as alternative to the IV therapy, like the quinolones and clindamycin and others, and not to use beta-lactam groups because of poor bioavailability. And this is their guideline for this for each type of microorganism. Take-home message: early diagnosis and active management can prevent serious complication. This patient is badly not diagnosed well and not treated well, and the result was disaster. MRI in early stages is very highly sensitive tool to diagnose the discitis. The elderly, especially over 75 years, and the presence of germs like Staphylococcus aureus infection are a risk factor for antibiotic failure. The surgery plan is individualized according to the surgical indication, and 2 weeks of antibiotic, 6 weeks of antibiotic is sufficient to cure the disease. Thank you.
Thank you so much, Ali, for this nice case and nice data. Ahmed, I will shift the talk to you just to know.
I think we have only 4 minutes for questions, so we will cut it short. So for Nini, there is a question from the audiences. They ask how you augment your decision in diagnosing the infection. Do you always send for a CT-guided biopsy to pick up a chip of that tissue for culture sensitivity, or you use always a broad spectrum antibiotic? Thank you.
No. Every case gets a 11 gauge core needle biopsy from soft tissue and not from abscess. However, there are some situations, especially chronic renal disease patients or chronic pneumonias, where you already have the bug beforehand from a prior existing infection, where you would treat them with that specific antibiotic. So even if you're very sure of the bug, but you don't have have the diagnosis on microbiology, you would want to reach out and look for a diagnosis.
Nini, can I comment?
So
there's some paper suggests that if you get a positive blood culture with a common microorganism, you can proceed with antibiotic treatment without taking biopsy from the disk.
Absolutely. So if you have some source of infection available, like if a blood culture is positive, you're probably talking about a septic patient. So that is that's something that's way out of our way. We would not be even allowed to do surgery. But even if you have a sputum positive or a lung biopsy or a bronchoalveolar lavage positive or a urinary sample positive, we are okay not to do biopsy. I hope that's clear, Ghazwan.
Yes, thank you. Doctor, I think there is always a question going in mind when everybody see TB of the body of vertebra. always juniors think that you can't fix with that infection, TB infection of that with that huge amount of TB of pus and the infected body of vertebrae. Do you always fix and put a cage when you see infected vertebra, or you start antibiotic and anti-TB, then you do the fixation for that patients?
No, actually, we have to see that whether there is an indication of surgery or not. If there is indication of surgery, as I have told you, according to the AO spine principles, if there is a neurological involvement or instability, or if there is resistant to ATT, or if there is a frank pus there, that is an indication of surgery. So if that is an indication of surgery, we straight away go for surgery and do the decompression, took the biopsy at that time, because there is no need for biopsy. Then we have decided the surgery, and we will take the biopsy from there. And of course, when you do the debridement, there is the loss of bone, and there comes the matter of reconstruction of that loss of bone. So in TB spine, because it is mostly it is an anterior pathology, and you have lost the vertebral body, so you can put the cage. These are the titanium cages, and usually they do not cause any problem or the biofilm formation or reoccurrence of the infection. Hope I answered the question.
I think this question already answered two other questions, because I want to ask you about which type of cage you always use, the titanium or the PEEK. I think you already mentioned that titanium cage is much better in case of infection. And I want to ask you about the biofilm implants.
These PEEK cages, they are very expensive, and our patients, they cannot afford it. We use it when we do the PLIF or TLIF, but there even we try to use our own cages. These are the local made cages, and they cost only $20 in our country. And because we prepared it in different sizes, and these are the hollow cages, and these are working very well in the TB spine.
Okay, Nini, if you face an infected spine post-surgery, and when you decide to remove the implants, do you always remove the implants, or you are following special criteria, and you are following a special time interval, whether to remove or just to go for wash and debridement and close again? What's your plan?
So for me, if it's a thoracic spine, I would not bother to remove implants. But if it's a lumbar spine, where in a situation I can't get away with a short fixation, like Muzaim said, percutaneous 2 screws and just decompression, but you need a longer fix, like Louis' case, where there's a long fix. I would like to do a long fixation, a short fusion, and an implant removal after 12 to 24 months. So that's one situation. The other is children. In children, invariably, you would need to remove implants because of growth, and the implant will give way. So after fusion is achieved, we electively remove implants.
Okay, thank you. Dr. Muzahim, do you have any questions?
No, thank you so much, Ahmed. I think we are run out of the time. So I would like to thank all our speakers for dedicating their time and to participate in this webinar. Thank you for our patient participants for their time. And I hope that we will meet again for next AO Spine events. Thanks a lot for all of you.
Thank you very much.
Thank you so much.
Thank you.
Thank you.